Hello everybody, my name is Caitlin Lang and I am going to be presenting on Myasthenia Gravis. To begin, I just wanted to give you guys a quick overview of what Myasthenia Gravis is. It's an autoimmune disease that affects the neuromuscular junction and causes weakness in the skeletal muscles. It is considered a rare disease. It only affects 14 in every 100,000 people, but it does affect women more frequently than men. And it does have two different mechanisms, the first of which is much more common than the second. The first mechanism is that antibodies will block and attack the receptors for acetylcholine, and the second mechanism is antibodies will block and attack the muscle-specific tyrosine kinase or MuSK receptors. There are two types of myasthenia gravis, which is ocular and generalized. As you could probably guess, ocular myasthenia gravis deals with eye muscle weakness and facial weakness, whereas generalized myasthenia gravis has to do with weakness in the extremities such as arms and legs. There is technically a third type of myasthenia gravis, which is called transient neonatal myasthenia gravis, but it is temporary, which is why I'm not really going to be focusing much on it, and it doesn't occur very often. Transient neonatal myasthenia gravis occurs when an infant is born with a mother that has myasthenia gravis. So right after birth, the baby will be experiencing symptoms that are very similar to an adult that has myasthenia gravis, muscle weakness, facial drooping, but the symptoms will actually resolve themselves in a few days or a few weeks, and the baby will return back to normal. So, a few common symptoms of myasthenia gravis include drooping of the facial muscles, which is actually the most telling sign of myasthenia gravis, weakness in the extremities or neck, like I said before, changes in facial expression because they're not really able to control what their facial muscles are doing, and blurred and double vision, which has to do with ocular myasthenia gravis, difficulty swallowing, shortness of breath, and impaired speech. There can also be found in patients an uneven gait or walking pattern because their legs are lacking strength in either one or both. So a quick graph here. I wanted to show the difference between male and female onset of symptoms. So the red line here is the onset of symptoms for females, and the black line is the onset of symptoms for males. As you can see, for females, the age of onset is much earlier in life, around 30 to 40 years, in comparison to men who experience onset of symptoms around 60 to 70. But in general, it does affect women a lot more than it does men. So a quick dive into each of the mechanisms here. The acetylcholine receptor blocking, which is what I talked about before and does affect the majority of the patients with myasthenia gravis. So in a normal muscle cell contraction, the nerve will release acetylcholine, which is meant to bind to the acetylcholine receptor that resides on the muscle membrane. However, in myasthenia gravis, the antibodies will actually attach themselves to these acetylcholine receptors and destroy them, which blocks the acetylcholine from even coming in and binding to activate the muscle cell contraction process. And the muscle-specific receptor tyrosine kinase is a little bit less well understood in comparison to the acetylcholine receptors. However, scientists do know that MuSK is responsible for synaptic formation and agrin-induced acetylcholine receptor clustering, which is an essential step in muscle contraction and starting to kick off that process. But in myasthenia gravis, antibodies will attach to and destroy these specific receptors, but this only affects about 5 to 8% of myasthenia gravis patients. So this figure here shows exactly what I was just talking about for the acetylcholine receptors. So you can see that the purple figure or shape is the nerve, and it's releasing these acetylcholines, which are the little purple dots. And the muscle cell on the bottom has these green shapes attached on them, and those are the acetylcholine receptors, and it has these little clefts which are meant to bind to the acetylcholine and trigger muscle activation. But in myasthenia gravis, these antibodies, you can see, are attaching to these spaces so that the acetylcholine can't get in and bind to the acetylcholine receptors, which means no muscle activation occurs, which accounts for muscle weakness. So, causes for myasthenia gravis as of right now are currently unknown. There are a few different possibilities as to what scientists think it could be. The biggest lead right now for causes has to do with the thymus. They believe that because most patients that have myasthenia gravis have thymic abnormalities, that could mean that the thymus is malfunctioning, and because they know that the thymus has to do with the elimination of autoantibodies or autoreactive antibodies, it could mean that in myasthenia gravis patients, or in patients that don't have myasthenia gravis yet, could actually be predisposed to developing it later in life if they have a hyperreactive thymus or malfunctioning thymus. However, that's not definitive just yet. They're still trying to work on figuring out an exact cause for it. And there's also no direct link to genetics or heredity. So as of right now, they can't say that a person who has myasthenia gravis could pass it on to their offspring, because only about 5% of patients who have myasthenia gravis have family members that also have it. There's also very poor understanding of the MuSK, or muscle-specific receptor mechanism, that I was talking about before. So as of right now, most of the research is being done towards the thymus for acetylcholine receptors. They're still trying to work on understanding the MuSK mechanism. So like I said, about 75% of patients that have myasthenia gravis have thymic abnormalities, whether it is a hyperactive or hypoactive thymus, but only about 15% of patients with myasthenia gravis actually have a thymoma, which is a growth on the thymal gland, or an enlarged thymal gland. So, moving on, myasthenia gravis can be diagnosed through a few different ways, the most basic of being a physical and neurological examination which tests muscle strength and coordination. The second type of diagnosis can be done through an androphonium test, which injects androphonium chloride, which is meant to relieve muscle weakness. So this is only to treat a symptom that is active in patients that are believed to have myasthenia gravis. There's also a blood test that can reveal possible high levels of acetylcholine receptor antibodies or anti-MuSK antibodies. However, this isn't a definitive blood test, so it kind of has to be backed up by something else, but it can be a good starting point. Electrodiagnostics is the most promising of all diagnoses. It discusses repetitive nerve stimulation using an electromyogram. So it tests the strength of the neuromuscular junctions and the synapse formations, which is the most essential step in muscle contractions. The least and last diagnosis that we'll be discussing here is the diagnostic testing, which refers to CT scans or MRIs, and this is the least promising because only 15% of people that have myasthenia gravis have thymomas. So CTs and MRIs can catch these thymomas, but it's not a definitive way to say, oh, this person has myasthenia gravis. So it's good for people who have thymomas, but even if the CT scan or MRI goes negative for a thymoma, it doesn't necessarily mean that the patient doesn't have myasthenia gravis. MG can be treated through a variety of different ways. For most people, they try to avoid doing a thymectomy if they can, because the thymus gland has a very big responsibility for the body. However, a thymectomy can be proposed for myasthenia gravis patients, which is a removal of the thymus gland in total. There's also the option of monoclonal antibodies, which is a process that targets autoantibodies that destroy acetylcholine receptors. The most commonly used is the anticholinesterase medications and immunosuppressive drugs. I'll get into immunosuppressive drugs in a second, but mostly anticholinesterase medications are used, and this slows the acetylcholine breakdown at the neuromuscular junction to increase muscle strength. However, immunosuppressive drugs can be used. They try not to use these as much as possible because it has severe side effects. But immunosuppressive drugs suppresses normal antibody production, which, as you could probably understand, causes a lot of severe side effects. So it puts the body at a very vulnerable state. But there's also the option of plasmapheresis, which is a replacement of the harmful plasma with the harmful antibodies with a healthy plasma with normal and healthily functioning antibodies. And the last treatment option is the intravenous immunoglobulins, which is a concentrated injection of antibodies that are pulled from healthy donors, which is meant to essentially shock the immune system and reset its operation system. Some current research for myasthenia gravis, the biggest research has to do with the biomarkers such as the T helper groups for MuSK patients. They found that in some patients with myasthenia gravis, they have found higher numbers of these T helper 17 cells, which means that it is possible that this particular subset of T helper cells are malfunctioning and not doing their job. So it's possible that in people who have biomarkers for T helper 17 or who have high numbers of T helper 17 cells, they could be at risk for developing myasthenia gravis or already have it. There's also research for the new pharmaceutical drugs and drug therapies, and there's also increased research in the thymus gland and its connection to myasthenia gravis. There was found in one article that in some myasthenia gravis patients, they also found that they were positive for Epstein-Barr virus, but there's not really any ongoing research in that. I just thought it'd be kind of interesting to include. But the thymus gland seems to be the pinpoint for research for most myasthenia gravis patients because they want to understand what is causing these antibodies auto-reacting to themselves. And these are my sources.